I'll be speaking on vertebral augmentation. Probably most of you who are listening have not yet done this procedure, and I think that some of the things that I'll be talking about from the technical aspects of doing the procedure will be a little difficult to understand unless you've actually seen some cases going on. I think that's been the experience here in Dar es Salaam. So let's get underway. Okay, so some of the data I'll be presenting is data from the United States, and it's going to be different from the epidemiological data that you'll find in Africa. In the United States, there are about 700,000 new compression fractures per year. The estimate is the medical cost is $1.2 billion per year in the United States. And the United States has an aging population, which is different from the African countries where the birth rate is high and the population is relatively young. Most of the fractures that we deal with are osteoporotic, not all. Some are malignant and some can be post-traumatic, and I'll talk about that later. The medical significance of the compression fractures is that the fractures are painful and elderly patients with osteoporosis become immobilized because of the pain. And then there are the associated morbidities that occur with immobility, such as venous thromboembolic disease, muscular deconditioning, the loss of normal activities leading to depression, and there can even be an increased mortality rate. The analogy that I like to make is with osteoporotic hip fractures, in which after a patient has an osteoporotic hip fracture, the excess mortality 12 months after the fracture is more than 20%, even if the fracture is fixed, and it's 70% if the fracture is not fixed. And that's because of the complications of immobility. With hip fractures, it's been clearly demonstrated that the earlier surgery has been performed, the better the functional outcome, shorter the hospital stay, shorter duration of pain, lower incidence of pneumonia, and lower mortality. Compression fracture treatment is not exactly analogous with hip fractures. Hip fractures, usually it's so painful, almost every patient with an acute fracture cannot stand. That's not true of compression fractures. Most compression fractures are asymptomatic. About 2/3 are asymptomatic. On 20% of CT scans in the US aging population, you'll see an incidental compression fracture, which will be asymptomatic. And even if the compression fracture is symptomatic, about 2/3 will improve within 3 weeks. So conservative treatment is very appropriate for most of these patients, and that conservative treatment can include bracing, although in my experience, it's a rare patient that tolerates bracing. It's a very uncomfortable device to put on to a patient. If a patient's pain is so severe that they can't wait, the pain is so severe that they are immobilized and will suffer from the immobilization, or they say, I can't do things that are important in my life. I can't take care of my spouse. I can't function. I can't buy groceries. Then those are indications to be more aggressive. Does surgery have a role? Usually not, because surgical fixation is going to involve plates and screws, and osteoporotic bone doesn't hold screws well, which brings us to vertebral augmentation, which is percutaneous cement injection. The various kinds of procedures are vertebroplasty or kyphoplasty. The abbreviations that I use are VP and KX. And then there are also some variants in which you can place hardware. So this is a cartoon showing what is vertebral augmentation. Simple vertebroplasty, you're putting a needle through the pedicle, or you're putting a needle through the costovertebral joint into the vertebral body. You can see the compressed vertebral body here, and then the cement is injected. Normally, when we inject the cement, the needle is more anterior than that, and you're filling the cracks in the bone with cement, and that allows the fracture to become immobilized. Usually it's the motion of the fracture that causes pain, and it's the immobilization of the fracture from the cement injection that then allows the pain to be improved post-procedure. Kyphoplasty is similar, except that instead of just placing the needle, you're putting a balloon through the needle. So here's the deflated balloon, and then you inflate the balloon with the intention of restoring height and reducing kyphotic angle. This is a cartoon for a reason. Usually you do not get this kind of height restoration. This is mostly a fantasy, unless the fracture is acutely fresh within a couple of days, in which case the fracture will be very mobile and you can restore height like that. And then for kyphoplasty, you deflate the balloon, you remove the balloon, and then you inject cement into the cavity that's left behind, and then the cement-filled cavity allows the compressed vertebra to maintain its height and keep the kyphotic angle reduced. What kind of imaging do we use to determine if someone has a compression fracture that might be appropriate to treat? Plain films are what are usually obtained first. They are the least sensitive. You can't tell if a fracture is acute unless you have a recent comparison, and frequently you can't even see the compression. The compression may be mild. The patient may have scoliosis, which prevents you from being able to see the end plates on end, and therefore you can't see if there's any compression. CT scan is very commonly used, particularly in the United States emergency departments, and it's very sensitive for detecting a fracture deformity. But unless there's hemorrhage or you see acute fracture lines, you usually can't tell if the fracture is acute, again, unless you have a recent comparison. If you're seeing patients who are very acute, for instance, in my practice, someone falls down, has severe pain, comes to the emergency department and has imaging done, their fracture might be 3-4 hours old, and you might not yet see any height loss, even though they do have a fracture there. The gold standard is really MRI, which is excellent for detecting edema. Edema is the marker for an acute fracture. It says that the fracture is active, and the presence of edema is also associated with a good pain response to performing vertebral augmentation. There are many patients who have contraindications to MRI. They have a pacemaker, let's say, that's not MRI compatible. And let's say that you don't have your information from CT because you're not seeing fracture lines, you're not seeing hemorrhage adjacent to it, and you don't have an old study. In that case, we would get a bone scan. If the bone scan is negative, the fracture is old. In general, if you have someone with very severe osteoporosis and the fracture is extremely acute, you haven't yet got your osteoblastic response to turn the bone scan positive. So a hyperacute fracture in a severely osteoporotic patient may have a negative bone scan. The bone scan can be positive for up to 6 months post-fracture. So even if the fracture is months old, no longer has any mobility associated with it, you're still getting osteoclastic activity, and you'll see activity there. That patient may not be a good candidate, even though the bone scan is positive. The most detailed kind of bone scan is one that's combined with a SPECT CT, similar to a PET scan, where you have a fused nuclear image with cross-sectional imaging. And that allows you to make sure that the activity that you're seeing on the bone scan is located in the vertebral body, as opposed to secondary to arthritis in the posterior elements, or just located at the end plates from degenerative change. Something that's new, which in theory could be as good as an MRI for patients who can't get an MRI, is dual energy CT. The articles that I've read make it appear that you can see edema in the vertebral body on dual energy CT just as well as you can on MRI. In my experience, I've tried it on a couple of patients on our dual energy CT scanner, and my diagnostic radiologist have been unable to make heads or tails out of what the images mean. Here's some images of how a bone scan can be helpful. This is a patient who's had 2 prior levels of vertebral augmentation, still having pain. The plain film, maybe there's a little bit of height loss there. I'm not really sure. This is the sagittal reconstruction from a CT. Clearly, there's some end plate depression here. Is that acute or not? We get a bone scan. Here's the standard bone scan. Is that within the vertebral body or not? The SPECT images allow you to see that the increased activity is within the vertebral body as well as within the spinous process. And you can say with confidence that this activity is coming from the compression and not from any of the other elements of the spine. What's the evidence that vertebroplasty or vertebral augmentation is clinically useful? The evidence has been, and I would say continues to be, controversial. The placebo effect for any medical intervention can be amazingly strong. And so these are 4 trials in which they were controlled for placebo by actually doing a sham procedure. Needles were put into the back. Sometimes local anesthetic was injected up against the pedicle. For some of them, they actually opened up the cement so that the patient could smell it, even though they didn't do a vertebroplasty. They didn't inject the cement. So as far as the patient was concerned, the patient could not tell if they got the procedure or not. These first 2 trials, INVEST and the Bookbinder trial, were published simultaneously, same issue of the New England Journal of Medicine, which is probably the most prestigious journal of internal medicine in the world. And the conclusion in the bottom was that in terms of pain improvement, there was no difference between the sham procedure and the intervention procedure. There were problems with these 2 studies. For instance, they took patients whose fractures were up to a year old. They frequently took patients whose pain scores were relatively low, so these patients were frequently not particularly symptomatic. As a result of these trials, particularly the Bookbinder trial, which was performed in Australia, they completely stopped doing vertebral augmentation, which prompted the primary investigator of the Vapor trial, who was also Australian, to say, we have to do these studies better. And so in Australia, he was the primary investigator for the Vapor trial. Bottom line, demonstrated that vertebroplasty was superior. Why was this trial positive and the other 2 trials were negative? First, he took patients with more severe pain. Second, he took patients whose fractures were fresher. And as an indication of how severe their pain was, 57% of these patients had such severe pain that they had to be hospitalized. He injected a lot more cement. He injected an average of 7.5 cc's of cement. In the Bookbinder trial, they injected 2.8 cc's. And I'll talk later on about inadequate filling of the vertebral body being a cause of failure to get a clinical response. There was another trial done called the Vertebroplasty 4 trial. And their conclusion, again, was that there was no difference. However, and I've covered some of this, the INVEST and the Bookbinder trials led the American Academy of Orthopedic Surgeons to state, quote, we recommend against vertebroplasty for patients who present with an osteoporotic spinal compression fracture on imaging with correlating clinical signs and symptoms who are neurologically intact. That's a very strong statement from a very respected organization. The problems, as I mentioned, with INVEST, chronic fractures, they didn't require an MRI to look for edema. And note this, half of the patients who were in the sham group crossed over to vertebroplasty because they didn't get better. That means that when the analysis was done based on intention to treat, half the patients in the sham arm got a procedure that probably helped, yet the credit for that goes to the sham. That's a real problem. Bookbinder, they treated chronic fractures. Edema was not required in very low cement volumes. The effect of these articles, after they were published in the US, vertebroplasty use dropped by 52%, kyphoplasty dropped by 40%. The next trial, sorry, the Vertebroplasty 4 trial, which I said was negative, subgroup analysis, 20% fewer patients treated with vertebroplasty compared to sham had severe pain at 12 months, particularly if they have moderate fracture deformity. Something else to keep in mind is that the bottom line saying no significant difference just tells you that the difference didn't reach a p of 0.05. If the p was 0.07, that's no significant difference. If they had studied more patients with the same results, it would have crossed the p equals 0.05. And the after analysis by those of us who believe in the procedure showed that if one more patient in the INVEST trial had had a positive result, it would have crossed the line to statistical significance. For the vapor trial, all the patients had relatively fresh fractures, more severe pain. They reduced hospital stay by 5.5 days. And this is important. In the sham group, 2 out of the 60 patients developed further collapse with retropulsion and cord compression within weeks of their being randomized to being a sham. If you want to analyze whether if only more patients had been treated in each of these studies that by themselves didn't reach statistical significance, maybe you put them together and it does reach statistical significance, you perform a meta-analysis which combines the data from multiple trials. That was done. And in that meta-analysis, vertebral augmentation performed better than conservative treatment for both short and long-term pain relief. The recently published Vertebroplasty 5 trial looked at patients that had more chronic fractures, but still had favorable imaging. They still had edema on MRI. And this was, again, a placebo sham randomized trial. And they found statistically significant improvement at 12 months in pain and quality of life in the number of patients off pain medications compared to sham. There was no difference in new compression fractures. And again, one sham patient with progressive collapse had spinal cord compression. Devastating complication. I talked earlier about the mortality data that favors early fixation of hip fractures, but I also said that spine fractures are not exactly the same as hip fractures. There have been multiple articles now looking at national databases to see, is there an improvement in survival with vertebral augmentation, that's KX or VP, versus non-surgical management, which is NSM. And article after article has found a survival benefit, a benefit of shorter stays, fewer patients with pneumonia, fewer decubitus ulcers, fewer patients with myocardial infarctions, deep venous thrombosis, and urinary tract infections. They pretty much all found, though, that kyphoplasty had better results than vertebroplasty for all of these long-term clinical outcomes. I'll discuss that later. A meta-analysis of 2 million patients, vertebral augmentation lowered the 10-year mortality risk by 23% for kypho and 13% for vertebroplasty. Another way of looking at the long-term effect is what happened after people stopped performing vertebral augmentation after the New England Journal of Medicine articles caused such a huge drop in procedure use. The mortality rates in these patients post-fracture increased by 4%, again confirming the mortality benefit from vertebral augmentation. This is a flow chart of who should be treated. It's a little bit complicated, and I've sent out my slides to one of the fellows here, and she'll be able to circulate them. This is a slide worth keeping. So if you're advanced imaging, that's your MRI, your bone scan. If it's negative, your symptoms are stable or improved, by and large, these patients should not be treated. But there are some modifiers, which this chart calls unfavorable factors. There are 4 unfavorable factors: progression of height loss, the fracture pain having a severe impact on functioning, more than 25% height reduction, and kyphotic deformity. If the advanced imaging is negative and the symptoms are getting worse, and you have at least 3 unfavorable factors, they recommend vertebral augmentation. If the advanced imaging is positive, you're more likely to get a good clinical response. And if the symptoms are stable or improving, well, 0 to 1 unfavorable factors, maybe you can treat, maybe you shouldn't. More than 2 unfavorable, treat. If your imaging is positive, your symptoms are worsening, go ahead and treat. Does the procedure have complications? Of course, every procedure has complications. And I'm not going to read through all of these. Complication rates are low, complication rates are higher with neoplastic fractures because sometimes the posterior cortex has been eroded with soft tissue and the posterior cortex is no longer able to contain the cement. I'll tell you what my anecdotal personal experience is with these complications. I've personally done, I'm going to guess, about 1,500 procedures. Many of those procedures had multiple levels, so it's probably close to 2,000 levels. I have never seen a transient neurologic deficit from osteoporotic or neoplastic. I've seen one permanent deficit, and that was someone in which I put in an artificial implant, and the bone collapsed around the implant, and the pieces were protruding posteriorly at T6, and the patient became paraplegic. So that was 1 out of 1,500. Fractures of rib and sternum, that's from placing the patient prone, and they have diffuse osteoporosis. And so they can fracture their bones just from the weight of their body being placed prone. Allergic reactions, I've seen 2. Infections, in my own 1,500, none. I believe one of my partners has had 1, so that's going to be 1 out of about 3,500. Symptomatic cement pulmonary emboli. I think I've seen 1 symptomatic. I've seen many asymptomatic. Hemorrhage or vascular injury, 0. Symptomatic hemothorax or pneumothorax, 0. As long as you keep your access needle in the pedicle or the costovertebral joint, you will not get this. Death, in my practice, we've had 1, and that was from cement toxicity, and I will talk about that. Many people believe that vertebral augmentation causes new fractures. They believe this because you treat someone for a fracture, and a week later or a month later, they come back with another one, and they say, clearly, the new fracture occurred after you treated me, so it must have been caused by your treatment. That's not so. All of those randomized trials have found that there was no increased risk of a new fracture in the vertebroplasty group. The reason that fractures occur frequently afterwards is that osteoporosis is a systemic disease, and the bones fracture one after another because they're all weak together. If someone has 1 fractured vertebra from osteoporosis, the risk of a new fracture in 1 year is 20%. If you have 3 fractures when the patient presents, that's a marker of the severity of the osteoporosis, and their fracture risk increases to 50% within 1 year. However, if when you're performing the vertebroplasty, cement leaks into the adjacent disc, you reduce the cushioning effect of the disc, and that does increase the risk of an adjacent fracture. Cement emboli, these are gross pictures, and I have to get these pictures from the literature because I've never seen this personally. So here's the cement that's been injected. It's going into paravertebral veins. It's going into paraspinal and then going up, and it's just showering the lungs on both sides. It would not surprise me if this patient is symptomatic because you're compromising a very large amount of the pulmonary vascular bed. Most of the time, The cement emboli are few. There was one article that said if you routinely perform CT scans on these patients, you'll see a cement embolus in about 20 to 30% of patients. It can be alarming to the referring doctor. They are asymptomatic. They do not need to be treated with heparin. They will not respond to heparin. The cement emboli do not have the same kind of vasospastic responses that blood clot emboli have. But this is clearly a very ugly picture. I talked about the death that we had, and that was due to what's called cardiovascular collapse bone cement implantation syndrome. Orthopedic surgeons are familiar with this. The cause is unknown. It may be due to cement toxicity. It may be due to fat emboli because you're squeezing bone marrow content out of the vertebral body and displacing it with cement. There's an increased risk with the more levels that you treat. However, articles have shown that you can treat up to 6 levels and not have a problem. In the United States, in general, you stop at 3 levels. It's not absolute. If I'm doing someone under general anesthesia for perhaps severe COPD and they can't tolerate sedation, or their pain is so intense that they can't even get on the table, I will do as many levels as I can to avoid a second anesthetic procedure. The first sign of the cardiovascular collapse is transient hypoxia, which can be easily confused with transient hypoxia from sedation. So if you see transient hypoxia, pause, and you might want to stop rather than going on to the next level. This is the way we set up our tray to perform vertebroplasties, and we probably do it differently than most other people in the world. We try to do it to save money. So the cement polymerizes. It gets hard, and the higher the temperature, the faster it polymerizes. So we mix up our cement, and then we deposit it in a syringe and put it on a sterile ice bath. And that can extend the working time of the cement from 10 or 15 minutes up to an hour, if not more. We also inject our cement using 1 cc syringes as opposed to using an injector kit. The kit can be simpler, but kits run about $600 each, perhaps more, whereas the disposables that we use for vertebroplasty tend to run somewhere between $200 and $300. So if we're able to save $300 to $400 per case, and we're doing 300 cases a year, we're saving hundreds and hundreds of thousands of dollars per year by doing it in this homemade way. The technologist fills up the 1 cc syringe from this reservoir of a 10 cc syringe, gets handed off to me. I take the 1 cc syringe and screw it into the hub of the access needle and then inject it slowly as I watch intermittently under fluoroscopy. This is a typical case. We've already done an L5 at this on this patient, and we're going to be treating L3. Cross-sectional imaging is critically important in how you plan your procedure. You can't see that there's a fracture here, but there is. We go to the cross-sectional image, and my intended needle path is to go transpedicular and end up in the midline in the anterior aspect of the vertebra. I will calculate that angle. This protractor calculates the angle off the horizontal, but when I perform the procedure, I will be fluoroing in the AP projection, which is a vertical line. So I take the 60 degrees that's calculated, subtract it from the 90 degrees of vertical. And so the angle that I want to go in under fluoroscopy is 30 degrees. When I walk into the room, I then take the C-arm, set it for a straight AP with the spinous processes right in the middle, and then I'll oblique the C-arm 30 degrees to get down to the pedicle. So here I've obliced it 30 degrees. I'm injecting lidocaine or bupivacaine down onto the pedicle, which is this oval. Then I'm taking my bone needle, either 13 gauge or 11 gauge, and going right down the pedicle. Here it is on the lateral view, it's entering the pedicle, and then I'll watch on the lateral view until I get close to the anterior aspect of the vertebra. If my calculations are complete, I end up right where my arrows were on my planning CT. The needle is in the midline and it's anterior. With the midline placement, it's likely that the cement will distribute bilaterally, and therefore I can have a unilateral needle placement as opposed to a bilateral needle placement. I'm injecting cement here. I've turned my fluoroscopic image into a road map, so I've subtracted away the background bone, which makes it easier to see the cement unless there's patient motion. If there's patient motion, you can't see it all. You have to turn the road map off. So the initial 2 or 3 tenths of a cc goes centrally and then starts going up through a fracture line and goes up beneath the superior end plate where there's a fracture line. I inject some more, so I've got good filling superiorly here, coming back, but I haven't filled inferiorly. At this point, I will repeat the roadmap, so I'll subtract out all of the cement that I've already gotten in, and I'll be able to see where my next injection of cement is distributing. And it's distributing beneath the superior end plate. It's beginning to distribute above the inferior end plate. And then my final result, my cement is distributed top to bottom, side to side, front to back. You don't need to get it to the posterior cortex. In fact, you don't want to do that because that increases your risk of having leakage out the back into the anterior epidural space. The weight-bearing part of the vertebral body is the anterior 1/3. So if you can get the anterior 1/3 filled, that's sufficient. If you get the back half filled, that's great. If you get back here, that's superb. Another routine vertebroplasty. Here we have an MRI. The CT scan shows you the obvious fracture there. You can see the lucency telling you that this fracture is recent, but you can't really tell that there's an adjacent level fracture here. The edema on the MRI allows you to see that both L4 and L5 are fractured. For each level, we'll then calculate our angle. So that's going to be 61 degrees. So my angle off the vertical will be 29 degrees. It'll be a different angle for each individual vertebra that I'm going to be treating. Needles are in at both levels, and you can see that there's a different cranial caudal angulation to each of these because of the normal lumbar kyphosis. On the frontal view, it's going to look like the L4 is going up and the L5 is going down simply because of the projection on the AP. You can't be parallel to the end plates of both of these at the same time because of the normal kyphosis there. And then post vertebroplasty, filled top to bottom, front to back, side to side at both of those levels. Cement can leak out into the anterior epidural space. That is not rare. The cement leaks out through the basivertebral vein and then comes out anteriorly. The first time you see that, it's frightening. You're afraid that you're going to be damaging the spinal cord. Depending on what level you're at, you're afraid you're going to be damaging the nerve roots. The vertebral body has normal concavity here. And so the cement comes out and it's a relatively thin amount. But on the lateral flora view, it looks thick because it's projecting from here back to here. You don't want to keep on injecting if you see that. That's your indication to stop injecting. Wait 30 seconds, 45 seconds for the cement to harden where the cement is leaking, and then you inject some more cement and it'll take the path of least resistance, hopefully someplace else. I talked about one of the problems with the bookbinder and Invest trials was that they injected a very small amount of cement. This is a case that was referred to me. Patient was treated someplace else in May of 2022, you can see the fluid-filled fracture line beneath the superior end plate, and there's edema both superiorly and inferiorly. They performed their vertebroplasty. The patient got zero pain relief, so they didn't get the benefit of the placebo effect, and then they were referred to me. Here's the MRI that shows the cement deposited, did not fill the fracture line, did not reach the bottom, did not reach the contralateral side, which still has edema. And here's where their cement is deposited. It's a plug here, does not come up and does not come anywhere on the opposite side. I place a needle on the left side, and then I inject more cement. And you can see from here to here that I've now filled superiorly, I've filled inferiorly, I've filled on the left side. But to get this good filling, some cement has leaked into an anterior vein, and some cement has leaked into the disc space. I prefer that this does not happen, but there is no increased risk of adjacent level fracture at this level because that level has already been treated with vertebroplasty, so I don't have to worry about hurting the patient. So redo vertebroplasty is due to insufficient cement injection, not filling the vertebral body completely and not filling the fracture line, and it is effective for persistent pain because you're then able to treat the underlying cause of the pain. When do I do kyphoplasty instead of vertebroplasty? I try to avoid kyphoplasty because it's much more expensive. In the United States, it's $2,400 versus $300 just for the disposables. Historically, kyphoplasty was done under general anesthesia in the operating room, and that makes it much more resource intensive. That was mostly when the company that made the device was marketing to spine surgeons. The degree of pain relief and disability is mostly similar. Kyphoplasty is usually bilateral, although there are now some curved needles which claim to allow you to perform a unilateral kyphoplasty. Vertebroplasty is about 80% unilateral. Kyphoplasty, as I shown earlier, has a mortality advantage, but I wonder if this is due to patient selection. If you're selecting patients who are healthy enough to undergo general anesthesia, and you're selecting out those patients who are not, then you would expect to see that patients who are healthier will have a lower mortality rate. So I'm not sure that kyphoplasty truly has a mortality advantage. Kyphoplasty can reduce kyphosis, in my experience, by not very much. It's better in a fresh fracture. If you have a badly comminuted fracture, you can get less cement leakage, but cement leakage is usually asymptomatic, and kyphoplasty has been reported to have a lower rate of new fractures. In my practice, I do about 80 to 90% vertebroplasties and 10 to 20% kyphoplasties. I will admit that I'm an outlier in the United States. Most people perform kyphoplasty instead. What are some other indications for vertebral augmentation or cementoplasty in bones in general? Sacral fractures are not rare in patients who have severe osteoporosis. They get bilateral sacral alar fractures with an H-shaped appearance on bone scan, and they can have severely debilitating pain. I'll tell you from personal experience, my mother fell down the stairs at my brother's house, following which she developed severe buttock pain. It took a while for me to figure out what her problem was and got an MRI, and she had bilateral sacral fractures. Her pain was sufficiently severe that she said to me, "I believe I have lived too long." We brought her to my hospital, and my partner treated her. At that point, she was 100 years old. So age is not a contraindication to performing these procedures. My partner treated her, and that night she took me and my partner out to dinner, and she said, "I've gotten a new life." So these treatments are life-changing. Osteoporotic fractures can frequently involve the pubic ramus. You can perform those under CT guidance, get a needle across the pubic ramus fracture and deposit cement from one side to the other. I talk mostly about osteoporotic fractures. Malignant fractures are also easily treated. You saw the complication rate was higher. You just have to be a little bit more careful, knowing that the cement can leak. You inject more slowly. The fractures can be treated even with epidural tumor involvement with a slow, careful cement injection. Lytic pelvic metastases can be performed to stabilize the lytic area. I have historically not treated traumatic fractures, feeling that these are young patients with good bones, they're not osteoporotic, and they will heal. However, it will take them several weeks to heal, and their mobility can be impaired. And in this study from the Journal of Neurointerventional Surgery, they treated young patients with post-traumatic fractures and demonstrated faster improvement in pain, functional ability, and return to work, all of which are important. One can put in implants, and implants can help in burst fractures, malignant fractures, destroyed posterior wall, because they can help to contain the cement that you're injecting. All of the implants are large diameter tools, and they are very expensive. There are 4 here. I've personally placed 100 kivas. We stopped placing the kiva after we had that one patient at T6 where the bone collapsed around the device and the patient became paraplegic. I've done, I think, 3 spine jacks. I found the procedure is effective, but the device is very large, and patients are quite uncomfortable. After doing the first one using sedation, I did the next 2 with anesthesia there. So for me, it's much more resource intensive to have anesthesia there. It's harder to schedule. It's much easier for me to just do a routine vertebral augmentation as opposed to putting an implant in. One technical thing that I always mention, these can be high radiation cases. It's AP fluoroscopy and it's lateral fluoroscopy. And lateral fluoroscopy is a thick part of the patient, and there will be a lot of scatter. So you want to keep the tube and the detector as close as possible to the patient to reduce the distance, to reduce the amount of MA that your tube needs. You must keep the arm of the patient out of the field. You're focusing on the bone. You may not notice that the patient's arm, the elbow, is in the field. If the arm is in the field on the tube side, you will get a skin burn because the tube side radiation is 100 times more than the detector side. Critically important to collimate down to the vertebral body that you're treating. In terms of reducing radiation dose to the operator, tight collimation is as effective as wearing a lead apron. No one would perform a procedure without a lead apron. And I would say that you should not perform these procedures unless you collimate to reduce radiation. You can drop the pulse rate under a fluoroscopy. Pulse rate of 4 pulses per second is adequate for body parts that aren't moving. And for vertebroplasty, you should not be having motion. I use a sterile radiation shield. You might not have that available in your country. They come in various brand names, RadPad, ScatPad. I, most of the time, do not have live fluoroscopy while I'm injecting the cement. I'll inject 0.3 of a cc of cement and then tap on fluoro to see where the cement went. And then I'll inject 0.3 more, tap on fluoro again, and I never see my hands under fluoroscopy. Clinical follow-up on these patients, they get a 1-week telephone call, they get a 1-month clinic visit, and I always tell them that if they're not doing well, to call us sooner. It is not unusual for patients to have residual or new pain, either from incomplete cement injection or new fractures. Sometimes they have sacroiliac joint pain because they've been walking in such a dysfunctional manner that they get inflammation in their sacroiliac joints, and a steroid injection into the sacroiliac joint can be helpful. And for osteoporotic patients, I always refer them to an osteoporosis expert for management to reduce their risk of getting new fractures in the future. So, summary of tips. Put your local anesthetic down to the pedicle. I use bupivacaine for its longer action. Some people claim that you're actually performing a nerve block of the nerves that are in the vicinity of the pedicle, and that can add to the pain relief that you get. And that's why it was important to do those sham procedures in which they could get the benefit of the nerve block, and you're able to distinguish that benefit from the benefit of the cement injection. Remember that bupivacaine is toxic if it's injected intravenously, and that the bone marrow is a venous space. So if your needle happens to have penetrated the osteoporotic bone, do not inject bupivacaine there. The cement injection should be slow to avoid leakage, and if the leakage begins, you pause, you wait for that to harden, and then you can continue with your injection, hoping that your cement is not hardened within your needle. The cement should fill the fracture line, extend top to bottom, side to side. Persistent pain can be another fracture that occurred since the imaging, quite common. Patients feel better after you treat them. They go back to their activities. Their other bones are weak, and they fracture another one. Persistent or new pain can be due to lack of complete filling. Do it again. And all patients get prophylactic IV antibiotics for skin flora. We usually use cefazolin. For those people who are allergic, we would use vancomycin. For patients who have a very severe immune compromise, such as they have a kidney transplant, they've had a recent systemic infection, they're an intravenous drug user, I'll add vancomycin to the cement. That changes the properties of the cement. It's off-label in terms of their regulatory approval. It makes the cement thicker, it gets hard faster, but it's something that I would do if I think that there's a very high risk of the cement getting infected, which is incurable, and the patient will be on lifelong antibiotic suppression after that. In conclusion, vertebral augmentation is safe and effective to treat vertebral compression fractures. Vertebroplasty, rather than the more advanced techniques of kyphoplasty or implants, is adequate for most patients. Patient selection is based not just on imaging, since so many of the patients have asymptomatic fractures. It's based on imaging and severe symptoms. You should have edema on the MRI if you're able to get an MRI. Adequate filling of the vertebral body is necessary, and again, urge you to have good technique, including radiation protection. Thank you. And please ask questions.
Thank you very much, Dr. Sachs, for this presentation. I have two questions. Both of them are just clarifications, really, about your opinions on parapedicular and extrapedicular approach for vertebroplasty. And yeah, that's the major one.
Okay. For lumbar vertebra, I always go transpedicular. For thoracic vertebra, you can go transpedicular, but the pedicles tend to be more vertically oriented. And if you're going parallel to the pedicle, you will not end up in the center of the vertebral body the way you will in the lumbar spine. I choose to do my thoracics going costovertebral, which you can also call parapedicular. I like that because the angle is good, and also the costovertebral space acts like a funnel, and it helps to keep your needle both stable and kept in the right direction. Going paraspinal, I prefer not to do, just to avoid the possible injury to an adjacent nerve.
Thank you very much.
Okay.
Yes, it does. Then the other thing was I saw your approach where you measure the angle of entry using CT, but I've seen another approach, say for vertebral kyphoplasty with a transpedicular approach, where the IR comes from 9 o'clock or 3 o'clock, depending on the side that they're at, and the hammer then the needle down into the pedicle, making sure not to traverse the medial wall of the pedicle
Yes.
before they're anterior to the posterior vertebral ligament. What's
Yes.
your opinion on that?
I think using fluoroscopy, going right down the center of the pedicle is technically easier rather than AP fluoroscopy and starting from the lateral side and angling medial. And then when you see the needle medial to the pedicle, you're hoping that you're in the back of the vertebral body. If you're doing a kyphoplasty, you don't need to end up right in the middle of the vertebral body the way I recommend for vertebroplasty, because you're going to be inflating balloons, which will then go towards the midline. So it's not as important to have the kind of angle that I use for vertebroplasty.
All right. Thank you very much.
Other questions?
Thank you, Prof, for the presentation. Just one question.
How about if you turn your microphone off and come here to speak?
So if we have accidentally entered our cement into the paravertebral veins and we suspect that the cement has gone into the lungs, what should we do like instantly, or what should we instruct the patient?
Okay, so the thing that you do instantly is stop injecting. You should see the cement enter the paravertebral vein. It's easier to see if you're using biplane imaging, because sometimes you won't see it on one plane. You'll only see it on the other one. For instance, if the cement is in front of the vertebra, you won't see it on the AP plane until it extends above the end plate. Or if the cement is on the side of the vertebra, which is the more common situation, and you're injecting in the lateral plane, you won't see it until the cement goes up. In addition, if you collimate as much as I do, you may not see it at all, which is why some of my partners criticize me. So you probably should not collimate down to a tiny little bit. You should see some on either side of the vertebral body. But when you see it entering the paravertebral vein, stop, wait, let the cement harden in, and then you can go ahead and inject some more. If it continues to go into the vein, you stop, you wait some more, and you do it again. Okay. And if the cement hardens in your needle before you got enough into the bone, you take the needle out and you stick the patient again. Sure. Other questions?
Maybe just
Okay.
another clarification. If my cement leaks into the superior intervertebral disc and the patient ends up with a fracture in the superior vertebral body, it is not my fault. No, because I said it doesn't increase the chance of.
I'm sorry, can you repeat the question for me? Yeah, can you repeat the question for me?
Yeah, you say that if cement leaks into an intervertebral disc, and then the patient ends up with a superior vertebral and adjacent vertebral body fracture, it's not because of the spine intervertebral disc cement leak. It's just that the patient is going to end up with that fracture eventually because of the ongoing disease, right?
Right. I'm not saying quite what you're saying. I'm saying that if the cement goes into the disc, it increases the risk of an adjacent level of fracture. It does not guarantee it at all. And the patient may indeed have gone on to fracture the next level anyway. But I'm just saying that the cement in the disc will increase the risk.
Okay. All right. Thanks.
Yeah. There are some patients where I've treated one, they break another, I treat the next, they break another. So let's say I've treated L1, L2, L4, and L5. I know that L3 is going to break next. It's just a matter of time. And the patient will say to me, can't you just treat L3 while you're there? And in the United States, if you do that, you won't be paid. And that's a strong disincentive to a physician to doing a procedure. I'm told that in Japan, they can do prophylactic vertebroplasty, but in the US, you won't be paid. And in addition, if you did it in the US and you had a complication such as an infection or some other complication, you would automatically lose your lawsuit because it's not standard practice, it's unaccepted practice in the United States. I see that there was something in the chat here. What's your clinical response outcome in your experience of doing these procedures in selected candidates? What timeline of fracture do you use in treating patients, or MRI is a must for edema? So the likelihood of getting good pain relief is better the sooner that you treat. If you have a practice like I have, where someone comes into the emergency department because of severe pain, they get a CT, they have a fracture, they call me. I say, we'll treat them tomorrow, get an MRI tonight. If I need it from the CT, sometimes the CT is clear, but the MRI is able to define whether there's a second fracture that the CT doesn't show. And about 20% of the time, there will be a second fracture. And then I'll treat them the next day, and they'll be discharged from the hospital the next day. So the sooner we can treat them, the more likely you are to get good pain relief. And we saw that in the 5 randomized trials, that the ones that treated patients out to a year and didn't insist on edema were negative trials. Will I treat someone who has an MRI that does not have edema? In general, no. If they beg and plead and understand that I'm saying, I don't expect this to help you, and they say, please, I'll try anything, treat me anyway, I will treat them. I haven't done that enough to be able anecdotally to say that it works. I think that if you see edema, you are on very safe grounds to say you have a very good likelihood that the patient is going to improve. Many patients will have chronic pain because they have chronic deformity. And if they have healed in that position, nothing you can do will restore height, and they will have continued pain. If you try to treat them, you will not get pain relief.